Welcome everybody. Good morning, good afternoon, or even good night to the third webinar, Decision Making in Colorectal Surgery. Our expert tonight is Dr. Marc Levitt, who does not need any introduction, maybe the most prominent active colorectal surgeon worldwide. Since 2018, he's chief and professor of the Division of Colorectal Surgery at the Children's National Hospital in Washington. And he's not only an outstanding colorectal surgeon, but a great teacher and a great friend for a lot of us, who taught us like many lessons in the past that made a difference for a lot of children with colorectal disorders. So Marc, it's a great honor for us and for EUPSA to have you here tonight with us. But before you have the word, I would like to introduce my co-moderator, Augusto Zani from the University of Toronto, Gaia Tamara from the EUPSA office, who set this meeting up again, and our three panelists, Alejandra Vilanova, Sanchez, a pediatric colorectal surgeon at the University Hospital La Paz in Madrid, Paola, who is the director of pediatric department in Italy, and Stefano Giuliani, who is a pediatric surgeon at Great Ormond Street Hospital in London. So including Gaia and Augusto, it's Italy 4 and Spain, USA, and Germany 1 each. So I guess we can't beat Italy tonight. So we have to focus maybe on the quality of our answers to make the difference. So as I said, Marc, we are all looking forward to this session with you on decision-making in colorectal surgery. And now you have the word.
All right, well, thank you again, Martin. I love this format. I love working with EUPSA, and we have a lot of wonderful friends on the call. So far, 98 participants, and soon we will all be together in Athens in September. And in the meantime, we will have to work this way, but at least we can all gather together. We picked some great cases to discuss that are particularly interesting, controversial, and there's not necessarily one correct answer. And that's what I hope will be provoked in the conversation. So hello to you all from all over the world. And let's go for the first case. So we need the first slide. I hope everyone can see their screen.
Yeah, Marc, sorry for interrupting. Let me just introduce our format with a few slides we have prepared. So Gaia, next slide, please. So first of all, we are all on Insta now since this week, so you can follow us. Next slide. Also on Twitter, we have a new platform there that we are relaunching, so it would be great if you shared activities there too with us. Next slide. Also the YouTube channel where this webinar will go also on from next week. You can, we will forward the link, and then you can actually listen to or watch the session again. Next slide. These are the videos on the YouTube channel. Next slide. And these are our next webinars. We will having one per month on these topics that you see here. We will have basic science coming up. Next slide. And there's a colorectal course also with Marc Levitt on September the 1st. In Athens, which is no lectures, but with a panel also, and pure brain on. So it will be, I think, a very exciting session. Next slide. And some of the activities nowadays are on that Stay Current app that a lot of you might have. And there's also colorectal quizzes on it. And I guess that's it. So we can start with the first patient. And I think Alejandra will introduce, right? Yes.
Yes. Okay. So this is a 9-year-old healthy female, normal growth curve with constipation for many years. Has a bowel movement once a week. The emergency department with a very distended abdomen, soft and non-tender and normal perineum. These are the X-rays and contrast studies. So in the X-rays, we can see a very dilated bowel. I would say this is a very dilated colon. And in the contrast enema, I do not clearly see a transition zone, but I do see abnormal speculations of the mucosa that remembers me what we usually see in patients with associated Hirschsprung's enterocolitis. Can you advance the slide, please? Gaia? Okay. So she was admitted for evaluation and treatment. After 3 days of enema, she was taken to the operative room for EUA and rectal biopsy. And the rectal biopsy showed no ganglion cells and hypertrophic nerves of 70 microns. After the clean out, she felt well and she was discharged home on 5 milligrams of bisacodyl a day. Since then, she has had 2 bowel movements a day, normal bowel control with no soiling and a flat abdomen, and had this X-ray. In the X-ray, we can see a small amount of stool in the rectum, but it's pretty clean though. So no dilation, no any more dilation. So can you advance the slide, please?
Well, let's wait, Alejandra, before we advance the slide.
Yes.
Let's talk a little bit about the radiology and then we'll discuss the case. So
Okay.
maybe we could just go back. Actually, the same images are here.
Yeah.
I really like your description of the radiology. We have a patient who comes to the emergency room with a very dilated, clearly colon, and ultimately gets a contrast study. I agree, it looks like an enterocolitis picture. And although remember, this is an older patient. So the older patients with Hirschsprung's tend to not have such serious illness like the very bad enterocolitis we often see in babies. So that's why this case is a bit confounding. And what did they do? They admitted her and basically cleaned her out as if she was an impacted patient. And they successfully got her cleaned out with enemas. And then they went to the operating room for an exam and found a normal exam. And a rectal biopsy shows no ganglion cells and hypertrophic nerves. So my question to you, the panel, is this Hirschsprung's disease? Let's hear from each of you.
I would say yes. This patient probably has a very short segment of Hirschsprung's disease, and she might be overcoming the functional obstruction of the internal sphincter because the lung of the aganglionic bowel is very short. But of course, this is Hirschsprung's disease with hypertrophic nerves and no ganglion cells.
Okay, does everyone agree? Paola, is this Hirschsprung's disease?
Well, hello everybody, first of all. If the biopsy were taken correctly, because she's an old patient, so that cannot be done by suction biopsy. And so I assume that was done correctly, surgically, at least 3 centimeters from the anal verge, because she's already 9 years old. So yes, no ganglia is equal to Hirschsprung, but because she has come to this old age without great discomfort, I would be very, very conservative in the treatment.
Oh, we will definitely get to treatment, and I appreciate you mentioning the technical details of the biopsy. That's very important. Obviously, we have to make sure the biopsy was done correctly. Maybe we can talk briefly. Are there some clues on the pathology that the biopsy, a biopsy, not this one, but a biopsy is not done correctly? Who can answer that? Maybe Augusto, what do you want to absolutely see in a biopsy before you conclude that it's a good biopsy?
So you want to see the ganglion cells, but also, I mean, what we do in my hospital is one of the questions on the chat is also the calretinin staining, but if it's positive, is also confirming the presence of the cells. The hypertrophic nerves are associated with a typical feature of Hirschsprung's with the acetylcholinesterase, but I think for me it's the absence of the cells.
All right, so I agree, and I think we have to be careful not to fall into any traps. One trap is if they do not talk about the nerves. And I've definitely seen patients that had, quote, no ganglion cells, but no comment of the nerves, and that is not Hirschsprung's until someone tells me about those nerves. The other thing that I want to know is that there is no squamous epithelium on the biopsy, because if there is, then the biopsy is too low. Another interesting thing to look for is, are there many eosinophils in the presence of ganglion cells? And in a baby, does anyone know what that could mean?
I think is that what they call the FPS, the food protein allergy.
Milk protein allergy. I'll tell you, once I had a patient that looked exactly like Hirschsprung's disease, had a classic x-ray. I took a picture of the x-ray and added it to my Hirschsprung's carousel of slides because it was so perfect. And the biopsy then came back with ganglion cells and eosinophils, meaning it was milk protein allergy, and I removed the slide because the patient obviously did not have Hirschsprung's disease. They had an allergy to the milk, but it looks very much like Hirschsprung's disease. All right, well, anyway, I think this biopsy was done well. And by the way, we know it was done well because Yaron Armon from Jerusalem sent us this case. He did a beautiful biopsy, I am certain, and it's clearly Hirschsprung's. So now let's go to the next slide and discuss whether this patient needs surgery. Okay. So what do you think, Stefano?
Yes, hello everyone. I think she's quite healthy. She has coped with this ultra short segment of Hirschsprung disease for 9 years. I understand without having enterocolitis and the suffering of constipation, which is also common in the general population. And I mean, if she is well now and she's able to pass stools as we have assessed after the clean out, really, I would observe her and see how she behaves. I mean, there is quite a lot of dilatation, especially on the first abdominal X-ray, and there is a component of megarectum and megasigmoid possibly, and that will take a while to shrink. But with a good bowel management, she may, cope well, without a surgery.
Yeah, I think.
But she may need surgery if she gets back on enterocolitis and further troubles.
I think that's very wise. I think the lesson here is that we treat the patient, not the biopsy. The patient has Hirschsprung's. This is not the first time I've seen a relatively well patient with Hirschsprung's that we did not operate on. And I think you just have to watch this patient very closely. And if they misbehave and start having obstructive symptoms, then you have to do an operation. But the way right now she was managed with a clean out and a low dose of laxative, I think it's safe to observe. Martin, do you agree?
Yeah, I agree. However, I would still be concerned that a severe enterocolitis at some time would make the patient really severely sick. But it's a judgment call you have to do with a patient. So yeah. Marc, there's an interesting comment from the chat. So Dr. Kumar is saying, is that ultra short Hirschsprung's? Could you comment how you define ultra short Hirschsprung's and maybe why this is not a case of that type?
Yeah, I prefer to not use that term. I think we should talk about Hirschsprung's anatomically. We should say rectal, sigmoid, left colon, splenic flexure, transverse or right colon, or total colon, Hirschsprung's. Ultra short Hirschsprung's is just confusing. If there are ganglion cells 1 centimeter proximal to the dentate line, it is not Hirschsprung's, period. Now you may find hypertrophic nerves, but I think those hypertrophic nerves are a secondary phenomenon to the constipation and the dilation. It doesn't mean the patient does not need an intervention and doesn't need help from a surgeon, but it's not Hirschsprung's. Hirschsprung's means aganglionosis, hypertrophic nerves, and the patient would benefit from a resection, in most cases, rectosigmoid resection. The patients who have ganglion cells within 1 centimeter of the anal canal can have severe symptoms, constipation. I've even seen patients like that with enterocolitis, but it is not Hirschsprung's disease. Remember, that patient might benefit from Botox because that patient their biggest problem could be just the sphincters, and it's the same sphincter dysfunction, and I'm describing internal sphincter achalasia, the same sphincter dysfunction that Hirschsprung's patients have. The only difference is that patient does not need any transanal rectal resection. So I would say Hirschsprung's or severe functional constipation in 2 different categories. And Mother Nature makes fun of us when we make categories. So she finds patients that are Hirschsprung's-like, but in fact have functional constipation. And there are functional constipation patients that behave like they have Hirschsprung's. And what is this case? This case behaves mostly like a constipated patient, yet we have a biopsy that shows it's Hirschsprung. So this patient is on the border zone between the 2. And someone wrote in the chat, let me just respond to that, can benefit from myectomy. I'm not a fan of myectomy. I would rather do I would rather do Botox treatment, and the patient eventually will improve. The problem with myectomy is it can give permanent damage to the sphincters. Augusto, you had a question.
Yeah, about the biopsy. So when you have a patient that is older, it is not a typical infant. It very much depends where you take your biopsy, especially if you're doing an open biopsy. Do you go above that centimeter, proximal to the dental line, 2 centimeters? What do you do?
Yeah, I mean, Paola mentioned 3 centimeters, and for me, that's a little bit far. If you can see the dentate line well, and you're at least 1 centimeter above the dentate line, clearly in columnar epithelium, I think you will get a good result. You obviously don't want to be too close to the dentate line because that normally has a zone of aganglionosis. But I think 1 centimeter proximal to the crypts, you're going to be safe. I want to recognize that we have a few cases to go through. So if it's okay, Martin, shall we go to the second case?
I think it's a great idea, yeah.
Okay.
Okay, this is the second case. This is a neonate, male neonate, born with an ARM who underwent a colostomy the next day from birth. And quite in a strange manner, several days after he was born, they noticed that a dot of meconium appeared at the base of the scrotum. So they took a contrast enema to define the anatomy of the distal colon, and this is what is shown in the picture. So the colon is filled with contrast, and the dot, which is at the base of the X-ray, is where you want to put the marker at the anal dimple. So next slide, please, Gaia. Okay, so with this kind of X-ray and information, what do you think is this anorectal malformation? Meaning he has a colostomy, colostogram, and apparently a big piece of rectum is missing up to the dot line, the dot point. but he has meconium at the base of the scrotum. So what do you think this is?
Yeah, so let's discuss this, because obviously this is not the typical sequence. Usually you go to the operating room for a colostomy when you're very confident that there's no perineal fistula, but sometimes the perineal fistula is not obvious, and the safe thing to do, of course, is a colostomy. And then a couple days after the colostomy, there is meconium on the perineum. So very strange. What do people think? Alejandra, do you have a name for this malformation?
I don't think I can comment on this malformation because the contrast enema is not done under enough pressure. So it might be a longer piece of bowel reaching the perineum, but we don't know because there is no enough pressure. The rectum is flat. It means we are missing some rectum there. So it is probably a perineal fistula that we don't know from that image.
Yes, so I really want you to burn this image into your brain. The distal rectum is flat. And where is it flat? It's flat at the PC line, the pubococcygeal line. If you drew a line from the pubic bone to the coccyx, that would be the line. And that is the normal compression of the rectum by the pelvic musculature. So you should see this image and you should immediately say, this is an inadequate study. Also say to yourself, how could it possibly be that there is no fistula, yet there's perineal meconium? Something is wrong here. And what's wrong here is that the radiology is trying to fool you, and you will not be fooled. So the adequate pressure would show a very deep and very reachable rectum in almost every case of a perineal fistula. Someone wrote in the chat that maybe it's a high rectum with a long fistula. That's a concept that comes from probably inadequate pressure. I have seen that very rarely, maybe once or two times. Hundreds of patients, the rectum is very, very low, within a centimeter or two. Stefano, do you have anything to add?
Not really. I agree that this colostogram is not well executed, and we will need basically more pressure. You know, I also, you know, I've read, I don't have direct experience, but I read a few reports saying that, you know, it is possible to have, you know, a high anorectal malformation with a very tiny fistula running in parallel with the urethra. And, you know, it is very important to define that, again, with more pressure, because the strategy for the surgery, it's essential to avoid damages to the urinary tract.
Okay, well, to follow up on that, what would be your surgical approach for this patient? I'm assuming all of us would do a repeat distal colostogram, and we can anticipate that the rectum will be much lower than what we see here. And probably we can delineate the fistula. And then, so what would be your surgical approach? Laparoscopy or posterior sagittal approach? Maybe Paola can take that question.
Definitely posterior sagittal approach, especially if the colostogram demonstrates what you just said, that the rectum is expected to be really very, very low. And
yes,
you can try to cannulate from where the meconium dot comes out, try to gently see if there is some fistula that leads you to the rectum, but without forcing or chasing anything. You go straight P-sharp, and the first structure you will enter is, it will be rectum.
now to follow up on Stefano's comment, which I think is very clever, very commonly there is a long fistula paralleling the urethra. So what do you do in that circumstance? When you open posterior sagittally and you find your reachable rectum, what do you do with that fistula? Martin, do you have a comment about that?
Well, there are two options. You can either leave it, just lay it open, it will epithelialize. I used to cut it out, but that's not really necessary. But my point here is I wouldn't even do a PSARP. I would follow the fistula, lay it open, and then it's more or less a perineal fistula where you can do almost a cutback. What do you think of that?
Well, I think it's a very wise point. The problem here is the fistula is in the scrotum. So this is not a perineal fistula type of malformation that's amenable to a cutback. But many males, the fistula is at the anterior point within the ellipse of the sphincter. And then I think a cutback, a minimal posterior mobilization is very reasonable. But in this case, we mentioned that the base of the scrotum is where the fistula is. So be very, very careful because the fistula is paralleling the urethra. You don't need to go anywhere near there. It will just disappear. You just do your standard mobilization of the rectum, make a nice anoplasty, and don't mess with the urethra because you will get into spongiosum bleeding, which is really, really unpleasant. All right, I want to make sure we get through our great cases today. So let's
Marc,
go to the
I-
third case. Yep.
Okay.
Sorry.
If you had seen the meconium pearl within the first 24 hours with a completely covered anus, so there was like, you know, even a dimple, would have you gone? So the concept here, I think the take-home message is, if you have these meconium pearls, for sure it's a low anorectal malformation. Maybe there's not a need for a colostomy. You go for
Yes.
a PSARP. You would have done a primary PSARP right
Yes.
away.
Yes, I would have done a cross-table lateral film to see how low is the rectum. And based on how low was the rectum on that image, I would go for a primary repair, knowing I was dealing with a perineal fistula. So
Thanks.
yes, you're quite correct. And someone noted that they would have liked to see a photograph of the perineum. And yes, we agree. We're just trying to limit some of those kind of photos because the last time we did a presentation like this, we were shut down because of those images. Now the next slide we're going to leave up very briefly because it has some of those images, but trust me, it was a perineal, tiny perineal pearl of meconium in the base of the scrotum.
But Marc, the last time we were on Facebook, so this concern is not a problem tonight.
Okay, well, I'm happy to hear that, but just your question is correct. We would love to show you a perineal photo, and just trust me, it would have shown a very normal looking perineum, obviously with no anus, and a little bead of meconium at the base of the scrotum. All right, let's go to the next case.
Yes, so next case is a 5-year-old boy who was born with anorectal malformation, underwent the 3-stage repair with a colostomy, a PSARP, and the stomach closure within the first year of life, and then presented back 2 years later with fecal incontinence. Now below you can see some intraoperative images of the assessment. I think, you know, in this case, the most important thing is how we approach a child with fecal incontinence or with problems a few years down the line after the repair. And, you know, I would advocate for a very thorough assessment, not only of the rectum, but also of the spine and of the urinary tract, to understand what is the best continence that we can achieve in this child, and if there are any other associated anomalies that can cause fecal incontinence. And of course, at the end, we need to also understand if the anus is in the right position, so it has been pulled through in the middle of the muscle complex or not. From what we can see here, the exam under anesthesia showed that the penia, the stimulation of the muscle complex is basically off where the opening, where the neoanus was created, and this will pose is probably the next questions and discussions.
Yeah, so let's leave this image up. This is a common scenario where in your clinic comes a patient who's had a previous PSARP and is presenting to you with fecal incontinence at the age of 5. And as you have nicely stated, Stefano, we have to figure out what is the anatomy of that PSARP and what are the associated malformations that could affect bowel control. So we want to know the quality of the sacrum and the quality of the spine, and we'd like to know what was the original malformation. And based on those 3 criteria, we can make an assessment of whether this patient with well done anatomy should achieve bowel control or not. In this particular case, the surgery has 2 major problems with it. One is the anus the anoplasty appears to have been placed lateral to the sphincter mechanism. And you can see that in the middle panel. The sphincter mechanism is in the middle where the anal dimple is, and the anoplasty is to the side. My question to you, Paola, how do you make sure to not do a mislocation when you do one of your PSARPs? What are your maneuvers?
During a regular PSARP,
That's correct, because obviously this patient had a PSARP and the surgeon put the anoplasty in the wrong place. And the question is, how do you avoid this mistake?
You absolutely need to check it with the stimulation, and there are many devices on the market to stimulate the muscle complex. And you want to stay in the midline within, you open along the midline, and by the time you go layer by layer more deep, you see the parasagittal fibers and the muscle complex coming from both sides. And
I was going to say, the one thing I like to do is I like to mark the sphincters before I start.
Yeah.
I think one of the problems is that a surgeon is excited, ready to do their PSARP. They open posterior sagittally, and then they get a little bit lost in where all the muscles are jumping around, and then they put it in the wrong place. But I think if you mark the anoplasty where your eye believes it should be and where the sphincter stimulation tells you where it should be, and then you match that location once you are open, you will very likely not make this mistake. Martin,
Marc,
can you, oh yeah, go ahead, Paola.
I always mark the place before, and I am not using the marking pen anymore, because by the time you arrive at the anoplasty,
it's gone.
Disappear. So I put 2 stitches, like one corresponding to the anterior margin and one to the posterior on both sides, so they will stay.
And
because with the Yep.
By the way, I want to just comment on what my friend Alan Mortel just wrote, which is one of the hard parts of colorectal care. Unfortunately, even with a perfectly placed anoplasty, fecal incontinence can be the final outcome. Alan, that is very philosophical. And when I first met you, you were not such a sage, but I guess you've gotten older. Here's the thing. You can do an absolutely perfect anatomic operation and not get a good result. And that is the most frustrating part of colorectal care, because usually in surgery, if you do a really nice technical operation, the patient does well. Well, that's not true in colorectal care, because they might have a bad sacrum, poor sphincters, a bad spine. But one thing we must guarantee as surgeons is we must give them the best anatomic repair that is possible. And that is our obligation. And then, of course, some will not achieve success still. This patient actually, I believe, has good potential for bowel control, but the anoplasty will never allow this patient to achieve bowel control where it is currently located. The other thing I want you all to notice, why did we do an MRI? And I think a pelvic MRI is mandatory in these evaluations, because what do you see on this MRI? What was the other thing done wrong at this original surgery? Anyone want to put in the chat what they think is the answer before Paola gives the answer?
I would like to make a comment going back to the how we mark these sphincters. It's very important to tell the anesthesiologist to avoid muscular relaxation before we mark the sphincters, because we can underestimate the strength of the muscular complex, and we can be confused whether we should put the anoplasty. So this is very important.
So Marc, may I ask a question? I realized that people put in like the Wheatlander retractor too early. From you, I learned to put on these Lone Star pins and really go slowly. Also looking at the parasagittal fibers, re-stimulate, and people rush into that, then spread with the Wheatlander, destroyed their midline, and then go deeper, and then that happens. Do you agree that's part of the problem, or?
Yes, I agree with that. I agree with that. You stay perfectly in the midline and gently go through and define all of your layers, and don't injure anywhere the muscles. I think the opening is very important for the ultimate closure. Remember, the PSARP is to open, then you find the rectum, and then you close. And the closing is just around the rectum that wasn't there at the beginning. That's the job. So a number of you got the answer correctly on the MRI. You see an outpouching from the urethra. I used to call this a posterior urethral diverticulum, but our urologist said, Marc, it's not urethral and it's not a diverticulum. Could you come up with a new name? So Vicky Lane, our fellow from the UK at the time, said, how about this? Remnant of the original fistula, roof, which I think is a much better term, because that is the old rectum. The surgeon went in posterior sagittally, found the rectum was too far away from the urethra and left behind the old distal rectum, which is why we must do a MRI, because we don't want to fix this rectum and not solve the problem of the roof, remnant of the original fistula. And by the way, I always do a pelvic MRI in these redo evaluations. And I also do a cystoscopy, because the MRI could miss it if there's no urine in the roof at the time of the MRI. And the cystoscopy can also miss it if the urothelium has healed over. There still could be a mass that is the original rectum. So I always do a cystoscopy and MRI. And someone wrote, does the roof cause symptoms? In this case, not yet. But I think if we're going to do a redo to relocate the anus, that is the time to remove this remnant, because that remnant can cause symptoms down the road. Most typically dribbling of urine after a complete void. Also, the mucus can leak into the urethra and they can void mucus. I've seen patients with stone formation in that distal rectum. And I have seen one case of an adenocarcinoma in a 30-year-old from a remnant of the original fistula. So just take a look for those. And this particular case looks like it was a low prostatic rectum. And I think that a redo, removing that, putting the anus in the correct location can really do wonders for this patient. So I want to, in the interest of time, want to make sure that we can go to the next two cases so we finish on time. Let's present case number 4.
Okay, I can start. This is one of my favorite topics. So this is an interesting series of pictures of female patients. And the question is, which one needs surgery and which one may not? So the first one on the left, panel A, clearly there is no anus, or
Wait,
maybe...
Paola, let's have them vote. Let's have them vote.
Okay, so
Let's talk A. Patient A, surgery or no surgery? Put them in the chat. And by the way, in the chat, also put what country you are from, because I want everyone to realize how incredibly international EUPSA is and how we are all fighting the same battles every day, and we suffer together, and we enjoy being able to suffer together. So most people, it seems, Paola, are saying, oh, we have Greece, we have Slovakia, we have Germany, we have Iraq, Bahrain, Indonesia. By the way, someone put Jakarta and they put Indonesia in parentheses so that I made sure to know, but I promise you I already knew the answer. Bolivia, Netherlands. Hi, Sana, how are you? Good to see you on this call. Zimbabwe, Cape Town, which is, by the way, I think in South Africa, India, Singapore, Vietnam, unbelievable. Pakistan. Do you like how I pronounced that? Correctly, right? Pakistan. Okay, surgery for A. Everyone agree on the panel? Stefano, you agree? Alejandra,
yes, I do.
You agree?
Yes.
Martin? Augusto?
Absolutely.
Thumbs up. Okay, because that's a perineal fistula that is clearly superior, anterior to the sphincter ellipse. Okay, Paola, continue.
So panel B, we see a hole in the perineum, which is really close to the posterior fourchette and not really normal looking anus because there are no wrinkles and there are questions on the diameter. So surgery for this, other checking besides just looking, or no surgery?
By the way, I put in my answer, Paola, and I put surgery, United States, and I am an honorary European. If you'll have me. About a year ago, there was some question whether the Americans were going to be kicked out completely of EUPSA, but hopefully you'll still have me.
Well, because you behave, basically.
All right. It looks like everyone wants surgery. How about the panel? Martin, Augusto, Stefano, you agree?
Yeah.
By the way, I will tell you, this is an interesting case. Back to the cutback discussion. The question is, do you need to mobilize the anterior part of this rectal wall? And what do you think, Paola? Does this require an anterior rectal wall dissection or only a posterior wall dissection?
Well, likely it needs to be fully mobilized, but you need to see where the muscle complex is. And from the picture, the pinky area where the muscle complex is looks completely posterior. So yes, I think upon stimulation, he needs full mobilization.
Yeah, so you're quite correct. Take the patient to the operating room, stimulate the anus. If the hole is too small, but it is inside the ellipse, just happens to be anterior, you can do a posterior wall mobilization only, essentially a glorified cutback. However, if the hole is not in the sphincter, you do not want to leave the patient with an anal opening with no anterior sphincter, because that can lead to incontinence. All right, how about C, Paola?
Marc, sorry to interrupt. Can I ask a question for B? So if you just did a Heineken-Mikulitz-plasty and wait until the child becomes continent or not, I think in these cases you have to balance relocation, the anus, and losing the dentate line and the canal versus
I agree.
Doing
Martin, I agree with you. I think this patient, what I would do for this patient is I would mobilize the posterior wall only and do a larger anoplasty than what you see here. And I would leave the anterior wall alone, provided when I stimulate, to confirm Paola's point, there is some muscle anterior. You don't need to do very much at all. The only goal is to make the hole adequately sized. The perineal body is long enough here and it will grow. All right, C, I think, is very similar to B. Let's talk a little bit about D. Who
D,
says, and now we're going to wait for everyone to respond. D, surgery or no surgery?
So D looks much different from the others because the
Don't answer yet. Don't answer yet. D.
I'm now answering, just describe.
Someone says the D dilate.
Dilate.
Okay, dilate, no
Right.
surgery. Also, we want to know where you're from. Anorectal angle. The angle is going to be normal when the rectum is so low.
Someone wrote, Paola is an influencer. I like that. I like that.
Yeah, by the way, Paola, you have like 100,000 followers on Instagram, right?
Still below my average.
The question is, do you have more followers than your age?
Okay, so that's, I'm fine. I'm fine. Thank you.
Is anyone operating on D?
To check
All right.
the slides first.
All right, very good. Now, Paola, tell them what you were seeing. Why is D so different?
Because D looks a normal anus, only really close to the fourchette. Normal anus because the wrinkles are 360 degrees surrounding the anus. Therefore, the muscle complex is there. And very likely when the muscle is all around, this is a stretchable anus. So for me, there is no need to take extra examination under anesthesia, provided that the anus is stretchable. And in a term baby, this is a long discussion still going on. In a term baby, the anus is around 10 millimeters. Someone goes for 12, someone for 8. We as ARNet consortium are going for 10. So in a 6 months old, I don't know, this baby looks older than a newborn. It should accommodate 13, yes, 14 millimeters without excessive stretching and, yes, screaming.
I agree. You cannot improve. That one is as good as it can be. All right, let's do the final case so we end on time. The final case. Who's presenting the fifth case?
I could do the third.
Go ahead, Alejandra.
Okay. 1-year-old with total colonic Hirschsprung's disease, ileostomy, and colonic biopsies in the newborn period. He presents with massive abdominal distension.
Okay, so that's all you're going to get. We're going to talk about this patient. So a total colonic Hirschsprung's confirmed by biopsy of the colon and has an ileostomy that has done well until this recent, very impressive visit to the emergency room.
Okay.
So Augusto, what do you think here? What's happening here?
So I see that there's small bowel loops that are dilated. So there's an issue with the ileostomy. I would assume that whoever did the ileostomy actually confirmed that it is ganglionic. That's important. I want to know whether I would examine the patient and look at the stoma itself and make sure that it's working okay, because it could be that there's if it's all of a sudden any stoma can twist or be obstructed.
Okay, so that's the obvious answer, and in fact likely the answer here, but I do want you to think about another very uncommon possibility.
Was the colon left in place?
Yes, the patient, so first of all, let me just reaffirm, Augusto, 100% correct. This is most likely a stoma problem, either stomal stenosis or a pathology problem of the stoma. remember, if you have a stoma in Hirschsprung's disease, you are stooling through a low pressure system. You should never get distended. You should never get enterocolitis. If you get enterocolitis in a stoma, you have to blame the stoma, because there is no way you should be having obstruction in a stoma unless there's something mechanically or pathologically wrong with that stoma. So I'm sure everyone thought of that. We did an exam. The stoma was somewhat narrow, and we needed to do a revision of the stoma. But I want you to think about something very uncommon, and that is the defunctionalized colon. We always seem to forget about the colon if a patient is already with a stoma. I have seen patients where the colon can develop a toxic megacolon, even though it is distal.
Yeah.
And why does that happen? Because the bacteria overgrow. And I remember a vivid case that I was convinced it was the stoma. And finally I operated, and the transverse colon was the size of Switzerland. And it was so thin and almost ready to perforate. So just keep that in mind. In this case, the patient's stoma was the problem. The biopsy was okay. It was a stenotic fascia, but the defunctionalized colon can misbehave. And there are patients occasionally who are not ready for their pull-through, but misbehave. They're not gaining weight. They're always distended. They behave like they have a low-grade enterocolitis. And for those patients, on occasion, you need to go in and remove the colon and leave a Hartmann's and keep them with their ileostomy until they grow and are very happy and are ready for their pull-through. And just to complete the discussion, once this patient is doing well, Alejandra, and thank you for your contribution in the literature on this very important point, when would you do their pull-through for total colonic Hirschsprung's disease?
I think this patient is 1 year old. He's ready to perform the pull-through. So we don't have to wait until the patient is continent for stools, for urine, as we classically thought. So we have good results doing the straight pull-throughs in babies around 6 to 8 months old. So I think this patient is ready. And I also want to comment on this topic about enterocolitis in the remaining colon. So in patients with Hirschsprung's, total colonic Hirschsprung's disease, I always tell the families to start to do irrigations once a week or once every 2 weeks, even with the ileostomy in place, because we can avoid enterocolitis and we can train family to do irrigations, because most likely in the post-hoc period, they will need to do irrigation. So I would recommend to start doing irrigations even with the ileostomy in place for patients with total colonic Hirschsprung's disease.
Yes, I agree, and I agree very much. And Alejandra, I'm very thankful for that article that you recently wrote. That the patient, if they're growing well and the ileostomy fluid is thick, they can have surgery somewhere usually between 6 and 18 months. I used to wait. I think that was a mistake. I think it should be done earlier. And then what surgery is up to you. My personal preference is an ilioanal, and many people would do an ilioduhamel, which is fine, but just make sure it's a very short pouch, because the duhamel can cause too much stasis and give some trouble. All right, in the interest of time, we are at exactly 11 a.m. in Washington, D.C., and who knows where it is in the rest of the world, but I think it's 7 p.m. in most of Europe. 5 p.m.?
5 p.m.
5 p.m., sorry. Listen, I really hope we can all be together at EUPSA. We need each other. We are owed a bunch of handshakes and hugs, etc., from all of our good friends. We have a special session on September the 1st, Wednesday, a pre-congress in Colorectal. And it's a beautiful program, and I hope everyone makes the effort to come. And Gaia, do you have any final thoughts? And I also want to recognize, and we can't thank Gaia enough for her incredible organization of EUPSA. She is the glue that keeps this very complicated puzzle together. And it's basically like a puzzle, and you open the box and all the pieces fall on the floor. And then Gaia comes and puts all the pieces together. And now it's a beautiful puzzle. So Gaia, any final thoughts welcoming everyone to Athens?
No, thank you very much for your nice words. We just suggest you to book in advance your flights and your hotel. So hotel reservations are still possible without any cancellation fee. So book your hotels and book your flight with a chance of cancel it just in case, but we really hope to meet you all in Athens. We will be there and wait for you.
Thank you.
All right, Martin, you want to close the session?
Yeah, also on behalf of Augusto and the panel, that was great fun, and thanks for joining. And we just realized we have to extend our Zoom subscription because we were limited to 100 participants. So next time we have to be bigger, can go bigger, and we will make sure we can have more people join. But those who could not make it today can watch on YouTube from next week on. And thank you again, Marc and Gaia. Everybody.
Thank you all.
Thank you,
It was a pleasure.
Thanks.
Thank you all.
See you
Bye-bye.
soon.
Thanks.
Bye-bye. Ciao.
Ciao. Ciao, ciao.
Thank you.